Okay, it's Dr. Silva, and this is public service announcement number 4. The evils of polypharmacy, also called polypharmacy. Polypharmacy is a term that's used to describe a medication regimen in which a patient is taking a lot of medicines. It's not really universally defined. Some people say at least 5 medications or more. That's fairly accepted, but there's really no set definition. But it refers to taking too much medication. And it's usually used in a negative context. There's some argument whether you could say you could justify polypharmacy, justify the fact that somebody's on 10 or 15 medications because the risk-benefit analysis of all of those medications was conducted properly and informed consent was obtained, and there's no redundancy, and there's no toxicity, etc., etc. So you could argue, but most of the time when people talk about polypharmacy, the connotation is a negative one. And you want to avoid polypharmacy. And really, that is the goal. If a person needs 20 medicines, then okay, I don't know anybody who needs 20 medicines, but if someone needs 10 or 15 medications, you would be hard-pressed to prove that. But the fact is that you can adopt some practices, and your doctors, plural, should adopt some practices to minimize the risk of that. And nowadays, it's a little bit better because they put in the medication lists and they coordinate with all the pharmacies, and a lot of times they'll have a master list, even if the patient isn't all that good about bringing in their list. But that's one reason why it happens, is because there are so many doctors. And so when you go to different doctors, everybody prescribes, nobody de-prescribes. Doctors are not in the habit of looking at a medication regimen and stopping medicines, taking medicines off. A lot of times they don't want to step on the toes of other doctors. They didn't prescribe it, so they're going to leave it. But a lot of those medications, really, they're PRNs that just to be taken as needed, but maybe the patient doesn't understand that, doesn't know that they're optional, and so they've been taking them all the time because the doctor prescribed it. That happens. The elderly are most at risk. They are the at-risk population, not just because of confusion, but because they have the most doctors. They have the most need for medications, and they spend more time going to the doctor, and they see more doctors, and they get more prescriptions. Another group that's at risk would be psychiatric patients. And that's interesting. I think it's because there are cases where doctors don't know what to do, and they're just throwing medication at patients. I certainly have seen medications that overprescribed for psychiatric patients, because a lot of times because something will be diagnosed and it's the wrong diagnosis, and the symptoms that the patient is having is better accounted for by one of their previous diagnoses, and then the person who made the new diagnosis then adds a mood stabilizer or adds an antipsychotic or just adds a medication to treat the diagnostic label. So they're treating the diagnosis, and they're not really thinking about the target symptom and really thinking about redundancy and looking at. I'll talk a little bit about ways to minimize polypharmacy. But there aren't any good statistics on polypharmacy. It really just depends on what study you look at, what population was looked at. But one thing that epidemiologists agree on is that it seems to be increasing despite modern technology, patient portals and that sort of thing. What is bad about having tons of medications, that some of which you don't need? And well, obviously it's the idea that the medicines may be doing you more harm than good. Individually, a medication, especially taken chronically, may have more adverse effects for you than benefits. And especially as you get older, older people don't tolerate side effects as well as they did when they were younger, in particular anticholinergic side effects. So when you have a medication that blocks muscarinic acetylcholine receptors, and lots of medications do that, then you get a host of side effects that fall under the umbrella of anticholinergic side effects, and they're poorly tolerated. They include dry mouth, which is a pain for anybody, but also they include constipation, which is a huge problem in the elderly because the incidence of constipation in the elderly is very high, and it can be very severe, and so you don't want to add anything to exacerbate that. It can also cause blurred vision, which again is a problem in the elderly. People ages, really, patients 50 and older have a degree of presbyopia. You risk making that worse. It's called cycloplegia because it causes you not to be able to accommodate, which is to constrict your pupil when you're trying to focus on close-up objects. So that's impaired. You also have impaired memory. Blocking acetylcholine is not good for short-term memory, so patients can be forgetful because of it. You can also have urinary retention with anticholinergic effects, and again, in the elderly that are very susceptible to that, it could really be a medical crisis if you get into anticholinergic toxicity. And it's also actually fatal if you overdose. That's rare, but you can overheat and you can get delirious, and it's just one of the many side effects that it's so common. And when you have a regimen that has 10 or 15 medications, you're going to have more than one that has anticholinergic side effects. It's just the odds. Other problems with having too many medications is obviously more side effects, more toxicity, more drug-drug interactions. There are medications that affect each other. They can cancel each other out if they have opposing mechanisms of action. They can be synergistic, and you may not want that synergy. And then there can be effects on each other's metabolism through the liver's cytochrome P450 enzyme system. Certain medications can induce or inhibit those enzymes, and that affects the metabolism of the other medication and affects the blood levels of that other medication, making it the blood levels either very low so that you're not getting any efficacy, or very high so that you're getting toxicity. The higher the pill burden, it's a concept called the pill burden, which is how many pills a person has to take in a given day. The higher that pill burden is, the worse compliance is going to be, because you have multiple doses throughout the day. You're going to forget, you're going to make mistakes, and especially, again, if you're older, or also the very young who may not be as responsible. And it's really the extremes of age that we worry about, and psychiatric patients especially. So what can we do? Well, as prescribers, we really should be looking at the medication list, and that is pretty much standard practice. You do see that. It's not the doctor that does it. It's usually the nurse or an aide, and that can be a little frustrating because a lot of times the person who's going down the list doesn't know a thing about one medication or another, so they wouldn't be able to spot anything. They're just updating, but then the doctor comes in and doesn't really even look at it. So it really should be looked at, especially if it's long. And any medication that was added for heartburn or headaches or restless legs, things that may come and go, conditions that are just occasional, and the patient's taking that medication every day, or they're carrying around bottles of dietary supplements, vitamins, things that they don't need, really should be looked at and taken off. And any medications that have directly opposing mechanisms of action. It's controversial. There are psychiatrists who would argue that there are some patients who would benefit from stimulant medications that increase dopamine, and also mood stabilizing antipsychotic medications that block dopamine. You would be hard pressed to convince me that giving a dopaminergic agent and then giving a dopamine blocker makes sense. And especially the patients that you are blocking dopamine in, let's say you're treating psychosis, there's an absolute contraindication to giving a medication that increases dopamine like a stimulant. So anyway, that's neither here nor there. You want to look at also medications that are redundant. So when we prescribe, we should think about, if you need a second antidepressant, make sure you've maxed out the dose of the first one, and make sure monotherapy has failed. You're on the maximum dose that the patient can tolerate. You've taken it for 6 to 12 weeks, and it's obviously you're getting a partial response or a non-response. And then think about, do you need to add or switch? And think about using a medication that has multiple mechanisms of action built in. And if you are going to augment, if this medication is working somewhat, but you're going to add a second agent as opposed to replacing it, make sure that the second agent doesn't have any redundancy, if at all possible, with the agent that you already have, etc., etc. So don't treat diagnoses, and I think we just need to be more mindful about it. And also, as physicians, really get into the habit of de-prescribing, because that really is justified. And a lot of times patients are taking medication from doctors that they're not even seeing anymore. The refills will run out, but some of those medications are over-the-counter medications. They don't need the doctor. And, well, the doctor prescribed it, and they're still taking it, and you ask them why, and they don't know. So educating the patient also. Thank you for listening.